Good afternoon, Dialysis Patient Citizens Educational Center followers. Thank you so much. Today is Wednesday, and you know what day that is? That's Wednesday, December 6th, and I am your host for this educational session with DPC Educational session here on Instagram. And thank you, Nancy Scott, for joining. And all of you guys who are logging on, thank you so much. It's Wednesday, December 6th, and I am here to answer your questions, talk about anything you may want to within limitations around dialysis and transplantation. This is the holiday season. We just went through Thanksgiving, and Christmas is upon us, the holiday season, Hanukkah, and there are so many decorations already out. We're getting in the spirit of celebration and giving and thankfulness, and it's really fun. I am actually in Hanover, New Hampshire, because I was teaching a course at Dartmouth for the medical students. So I'm not on location. As soon as I finish here, I'll be heading back to Delaware. So again, I am Dr. Scantlebury. I'm the medical consultant for dialysis patient educational process and actually educational team. And actually my talk today was on disparities in kidney transplantation. How do we get on the patients on the transplant list? How do we get patients to understand that transplantation is a choice for end-stage renal disease and does not have to happen after dialysis, and that you can be educated about the process of being listed for a kidney transplant before you hit dialysis, and that you can continue that process and avoid dialysis altogether. So how does one begin the transplant process? Generally, patients are diagnosed with end-stage kidney disease, or if they are diagnosed early because they're followed by their doctors and they're seeing that there's a decline in kidney function. Most patients are warned by the time they get to stage 3 that there's kidney function and deterioration, and that they need to be careful and continue to be monitored appropriately. Oftentimes, they're referred to a nephrologist who then work with them to figure out why they have kidney disease, what are the underlying issues, do they need a biopsy, are there other things that can be corrected. And while diabetes is the number one cause of kidney failure leading to transplantation, high blood pressure is the number one cause of kidney failure within African Americans. And while it's often late diagnosis, it's often difficult to treat, and patients go on to end-stage kidney disease much faster and at a higher rate compared to Caucasians. So a Caucasian patient would be diagnosed with stage 3 and may go all the way through life with a stage 4 without ever ending up in kidney disease. But compared to an African American, they would accelerate the disease process much faster. And so it's very important to understand the consequences of high blood pressure, the consequences of lack of control of diabetes, because those are silent diseases, and therefore it makes it very difficult for one to understand, well, I'm still making urine. Why are my kidneys not working? They're working because I'm peeing fine. Making urine does not necessarily mean your kidneys aren't functioning. Many people are on dialysis and still make urine, so don't use that as a marker. Kidney disease is very silent. Many people don't have symptoms or are very generic symptoms. You're feeling fatigue, you're tired all the time, you may have some swelling in your legs, and that's very deceiving because you may just chalk that up to perhaps I'm working too hard, I'm not getting enough rest, and many different things. So you want to be able to let your doctor know, and if you change doctors, be cognizant of your kidney disease, let them know you're interested in a transplant, not just dialysis, and that if you have a living donor, that you can proceed to transplant without even needing to be on dialysis. There's certain things that make you eligible for a transplant, and to understand that there are things that you will need to do. We want to make sure that you're going to survive and do well after your transplant. So we want to make sure that you don't have any cancers. that you don't have. If you have underlying heart disease, they're going to send you to a cardiologist to make sure that the necessary heart work is done, whether it means getting a cardiac cath, whether it means medication optimization to make your heart better. And if you have peripheral vascular disease, you may have to have stents placed. All those things are important for knowing that your survival will be the best there is after transplant. Not everyone is going to be eligible for a transplant. I mean, certainly if you're older, and we do not add patients to the waiting list over age 75, because we know that, number one, it's difficult to get a kidney. Two, the comorbidities of the existing disease process, whether it's of the heart or other processes, as well as the immunosuppression, the anti-rejection medicine that they have to take, may jeopardize their life much more than the advantages of getting that kidney transplant. If they're going to be sick all the time after the transplant, or succumb to many infections, or heart gets worse, those are things that may shorten their lifespan more than the benefits of going through this procedure, which itself is not a benign procedure. What if you're not eligible? What options are you have? Then certainly the other two treatments choices are going to be either hemodialysis, peritoneal dialysis, or no dialysis at all. Some people, as they get older, may decide that they're too old for transplant and may not feel like they would benefit for transplant. My dad was 89 when he was diagnosed with kidney disease, and the transplant center in New York wanted to consider him as a transplant candidate, and he said no. He looked at dialysis, but he did not want to do dialysis, and so he opted that he would just live his life out without dialysis. And he did. He lasted until he was 95 years old without dialysis, and he did relatively well. Actually, he did excellent until the last 4 months of his life, when he developed, fluid problems and issues with diet restrictions. So, transplant is not for everyone. But if you're young and you want to continue to live, I have a patient now who is coming to be evaluated for her 4th transplant. She's had 3 transplants already, and she's been on dialysis for the last 20 years, and so she was on peritoneal dialysis and has done well over those years. So it's important to know that, yes, you can survive on dialysis, but it requires you to be very compliant with your regimen. You want to make sure, certainly with hemodialysis, the options are better long-term survival with home dialysis or intermittent home dialysis, as well as evening dialysis on a daily basis. So the more often you do that dialysis, the better off your body is, because now it's getting a chance to get rid of all those metabolites that need to be excreted from your body. And so that's important. That's important in terms of how you do. So peritoneal dialysis patients are definitely have an advantage in terms of survivability over hemodialysis, but now with home dialysis and patients doing it at home, the survival certainly can be much better from that perspective. Question: a patient has been offered a kidney from a donor with diabetes. Will the transplant patient get diabetes? Generally not. Diabetes is an illness that's systemic to the patient in terms of their own islet cells not working properly or not making enough insulin. That transplant will not transmit diabetes from the donor. The recipient themselves, or the transplant patient, may be at risk for diabetes, just type 2 diabetes or post-transplant diabetes, just based on age, the underlying risk factors, and also just from being on immunosuppression. The prednisone and the anti-rejection medicine does have an incidence of about 10 to 12% risk of diabetes post-transplant. So certainly watching your diet and being monitored for post-transplant diabetes. A lot of people who are restricted in their diet pre-transplant, now they have a transplant, they go off and start eating things that they were restricted on and eating too much, tremendous weight gain. And so that in itself can be a risk for consuming too much calories and some patients, about 10 to 15% of patients, may end up with post-transplant diabetes. That doesn't come from the donor. That's just your underlying risk, whether your genetic predisposition, whether you have a family history of diabetes. That may be not necessarily, that may put you at risk from that standpoint, but it's not going to be from the donor itself. Is there a certain number of transplant an individual is allowed? There's no cutoff, but what happens is that the more transplants that you receive as a foreign entity, the more your body is going to react to that foreign entity with the development of what we call antibodies. So with each further transplant beyond the second one, your body becomes sensitized in that the genetics of those previous transplants are now in your system because there's some remaining tissue that may be existing, and your body was exposed to something foreign. It developed antibodies against that donor, and now you have made antibodies that stay in your system from the previous exposures. So by the time you get to transplant number 3, it may be possible you may have much more rejection because your body has more antibodies, and so the longevity of repeated transplants certainly gets shorter. By the time you get to transplant number 4 or number 5, it may be difficult to find a match, because even though someone may want to donate to you, the possibility that you have developed antibodies and will react to that donor is so much higher. So many patients wait on the list for a long time, waiting for a 4th transplant. I've only done a few 4th transplants in my 30-year career, probably less than 5, and I've only done one patient who's actually received a 5th transplant. You also run out of space to where you will put these transplants because they need to be placed near the bladder. So we start on whichever side is first, left side, right side first, left side second. 3rd transplant, we remove the 1st transplant on the right, and we go back on the right again. The 3rd time you go back on the left again. Oftentimes, if the kidney is still in place and you don't want to, and it's hardened or calcified and it's difficult to get out, you will leave that in place, and you may put it somewhere in the middle, but close to the bladder. So all these transplants have to go in the pelvis, close to the bladder, and so the amount of space and the degree of vessels, the length of vessels that you can use will often inhibit patients from receiving additional transplants because of development of atherosclerosis, hard plaque disease, where we're unable to make those connections, and that there's no good vessel left to be able to connect the kidney to. So that's often a limitation in placing a 4th kidney or even a 5th kidney. Many patients wait very long for those, and so therefore may not even get an opportunity to get that 5th transplant. So thank you very much for that question. We don't say this is your limit, but each time around is different, but each time around you are matching to a different donor set, and so each particular donor is different than the first donor. So I hope that helps, and thank you all for joining. I'm Dr. Scanterbury. Again, I'm the medical consultant for Dialysis Patient Center Educational Process, and so we hope that you had a wonderful Thanksgiving and looking forward to the upcoming holiday for this in December. It will just be in a couple of weeks. We're all excited. I know that those who are in school are looking forward to having a vacation break, and whether it's college or medical school or just high school, all the kids are excited to be home for 1 or 2 weeks. And so you want to be able to, if you have family members coming in, we know that COVID is on the rise. We just had a session here with our COVID team about rising numbers of hospitalization and rising numbers also of deaths with COVID. So encourage your family members, your friends, to get the new latest a monovalent vaccine. People say I'm fully vaccinated. There's no such thing. It used to be that you needed to be fully vaccinated before 2023, but with boosters and the change in the virus makeup and the modifications that come with the virus over time, we have to modify the vaccine. So the current monovalent vaccine is not the same as the vaccine you received in 2021 or 2022. As the virus changes, you have to receive the new vaccine. So your old vaccines offered protection for those viruses that were current at that time that are no longer around. And so it really is imperative for you and those around you, those coming in your vicinity. If you're not sure, make sure you wear a mask as you travel around, go into the malls, because as a transplant patient and as a dialysis patient, you are much more at risk to end up with hospitalization or even death from COVID infection, which means you can perhaps end up being hospitalized or potential for that infection to become pneumonia and progress to something worse. So definitely, I know we feel like we are all COVID fatigue, but we do want to make sure we get our protection in place. And if you also need your flu vaccine, please go ahead and get that. If you're over age 60, then you qualify for the RSV, but make sure you check with your doctor to make sure that if you're immunocompromised, you may not be able to get that vaccine at this time. Should a transplant patient who had a fistula have it removed after transplant? This is always a question that patients ask because they're feeling like this fistula that you've done dialysis with for many years now isn't necessary. But the fistula is made from a vein that has been turned into a rapid flowing blood vessel by connecting it to an artery. And over time, that vein enlarges and it's actually very stuck to your tissues under your skin. If you have a graft could be removed. You can go in and take that out and cut both ends and tie it off. But because the fistula the vessel is thin and it's very difficult to remove without ripping and causing much more injury and blood loss, it's often easier if you anticipate that this is your last go around, you can have it ligated. It's very difficult to remove, but in some cases we can have the fistula ligated. We usually tell patients to avoid doing that because often it can be used for blood drawing. If you need to have plasmapheresis for any reason, if you need to have long-term infusions for something, sometimes it's easier to use your fistula if you know that you're no longer going to be dialyzed. Kidneys don't last forever, so we tell patients to be careful about anticipating removing your fistula until we know that your kidney is going to be long-lasting. Some patients, their fistula on that side delivers a tremendous amount of blood flow to the heart and can overload the heart when the flow in that fistula is tremendous. So in those cases, because the heart is seeing this very fast flow rate, like a waterfall being dumped back into the heart, especially on the left side, from your fistula, oftentimes we will recommend ligation of that fistula because it's contributing to underlying heart disease. So that's very important, not just for the sake of ligating the fistula because it's there, because if that kidney fails and you ever need another transplant, then you've destroyed your access. So it's not standardly recommended unless it's life-threatening or important in terms of the protection of your heart. And that's generally our stance on that. So many patients, sometimes their fistulas with the kidney functioning and no need for that high flow rate. We see often that the fistula itself will thrombose from just lack of disuse. It would usually have some pain and discomfort, but once it thromboses, it would obliterate itself over time. as long as it doesn't become infected by intervening into that clot in any way. So thank you for asking that question. And it's one of those things that we battle with in terms of patients after transplant wanting to know, can I now take out my fistula? And like, no, not really. Well, just keep it for a while and let's see what happens over time. So thank you. How do you overcome a fear of transplant? Well, we all have fears. It's okay to be fearful because transplant is not a benign process. It's going to come with some potential complications. It may not go smooth, but that's really about life. We may leave our house and go outside and get hit by a car. Some things we don't necessarily anticipate. There are things but we do our best to understand the consequences, weigh the risk and benefits, and say, what if I don't do this? How will my life be? If I do it, what are the benefits of it? Will it increase my chances of survival? Would it make me live a longer time? Would I feel better? What are the benefits? And everything has benefits and everything has potential risks and complications. But it's about weighing the risks and benefits of those and say, okay, I'm fearful of this, but I know that the outcome is going to be more beneficial to me. And you really do your research in terms of how can you optimize your condition so that you do your best to have a positive outcome in terms of recovering properly or not having major complications. You can sit down with your doctor and discuss various ways. What are the issues that I anticipate? How can we avoid those situations? But it's normal to have a fear. When I give a talk, sometimes I have anxiety or I may be a little fearful of, am I going to do a good job? And so with every time I do a transplant, they're all different. And so for me, it's that anticipation and a little bit of anxiety and, asking to say, well, ask God to help me get through this and that he will guide my hands and that I will do the best that I can. So it's okay to have fear, but you want to be able to talk through that fear, make sure you're comfortable with your decision and you're okay moving forward despite your fear. And you just have to trust and have a physician and a care team that you can trust and that you can count on to do the best possible for you. And I hope that answers your question. It may not be the correct answer, but that's what my thoughts are in terms of overcoming the fear. Hi, Fez. Thank you for joining. Long time no see. Appreciate you coming on. So any other questions? So you have a few more minutes left. We know that the holiday is coming up. We want to make sure that you do your best, and there's a lot to eat. There is a lot of fun, family to enjoy, but you want to be careful that you don't overdo it. For those of you on dialysis, you want to make sure that you limit your fluids. If you're not making urine, if you have to skip, I think Christmas is a Monday, so those of you who have that holiday, who've dialyzed on Mondays may not be able to be dialyzed. So you're going to go some extra days. So don't put your heart in jeopardy by consuming too much. So be careful and not risk your health for that short period of time. So make sure you enjoy the festivities, but limit your portions. And limit your foods that contain phosphorus unless you're going to take some binders. And really try your best to enjoy the occasion with your family, but you don't want to end up in the hospital right after the holiday. So my advice is to everything in moderation. Get out and take a walk if you can, if the weather is good. Burn some calories that you consume, because we all will be consuming extra calories. I know I did over Thanksgiving, but I'm now trying to be a little bit more restrictive in terms of sticking to vegetables, cutting out my carbs, because I know another holiday is going to come up. So I'm going to make a few sacrifices so I can perhaps lose a couple pounds before Christmas, so I can indulge or a tiny bit more. but I want to be able to get rid of those things that are not necessarily beneficial to me. So for those of you who are on dialysis, be careful with the potatoes. You know what things you can eat and not eat. But the biggest thing is you want to, most of the time patients end up in the hospital with fluid overload and pulmonary congestion after the holidays because they've indulged in too much of volume that they're not able to get rid of. And that's a strain on your heart. So pay attention to that. Do what you can to minimize your salt intake, your sugar intake, as well as your fluid intake, and enjoy your family and protect yourself. If you know there's those people who are coming over to your house who are not vaccinated, make sure to wear your mask. Make sure that you wash your hands frequently because you do not want to get sick from having company over or from going to visit others and then end up in the hospital. So those are my cautions for you. We want you to have fun and enjoy, but we don't want you to reap the consequences of that. We have about 3 to 4 minutes left. If there are any other questions that you may have, please put them out there. I think I answered all the questions. Scrolling back to see, we want you to also continue to encourage your family members to get checked so that if there are other members in your family who may be at risk for kidney disease, make sure they get in their blood work. Make sure that if they're kids, young teenagers, that they get in the urine check for protein, a very simple test that can detect early kidney disease. And the more we educate those around us, the more we can help eliminate the need for long-term issues and long-term complications. So if you are the person in your family who have kidney disease, educate those around you next time you come together for a family gathering, knowing that kidney disease is silent. We don't know that we have kidney disease because the symptoms are very, very vague until you show up in the emergency room with a creatinine of 20. Many people are unaware that their kidneys were failing or that they were not working at all, and that fluid that was accumulated and that fatigue and that tiredness was all due to kidney failure. So use your knowledge of your own disease process to educate others, educate them so that they may be able to benefit and have hopefully a smoother course by early diagnosis. And early diagnosis gives you the ability to have many more options. You can think about, well, can I avoid dialysis? Can I go straight to kidney transplant? Can I do peritoneal dialysis? But when you're diagnosed late, you go straight to hemodialysis because it's an urgency of getting those metabolites out your body. So we want you to have a healthier lifespan. We want you to educate your family so that they can also understand the risk of kidney disease, the risk of diabetes, the risk of hypertension. And so use your knowledge and understanding of your disease process to help others. I thank you so much. Enjoy the rest of this month. Enjoy the holiday coming up. This is our last session for the year. So I will see all of you in 2024. Have a wonderful day and God bless. Take care.